Okay, now let's talk about alcoholic liver disease. Alcoholic liver disease. We have the hepatic steatosis. Hepatic steatosis, macrovesicular fatty change. Microvesicular was in Reye syndrome. That was due to aspirin. Aspirin ingestion by a child. Okay, so macrovesicular fatty change. Look at in picture A. You have steatosis, accumulation of fats. Look at these fats within the hepatocytes. Fats within the hepatocytes. Okay, and let me erase all of this, and that may be reversible with alcoholic cessation. So pathogenesis of alcohol-induced hepatic steatosis is due to the fact that alcohol decreases free fatty acid oxidation. And let me just contrast that with aspirin. Aspirin decreases beta oxidation of free fatty acids. Excuse me. When you have a decrease in free fatty acid oxidation, it leads to those free fatty acids or triglycerides, they accumulate within the cytoplasm. Those triglycerides, they accumulate in cytoplasm. Okay, and a nucleus is pushed towards the periphery because you have so much. Push, not neutrophil, but nucleus is pushed towards the periphery. Looking in the picture, look, it's sort of like a signet ring appearance when you see. I'm not saying it's a signet, but just think about it same way. Right, the nucleus has been pushed towards the periphery, and you have all the fats, the good triglycerides being the cytoplasm. Okay, so all that occurred. Why? Because you have a decreased free fatty acid oxidation because you have taken alcohol. Okay, but if you were to have an alcohol cessation, everything is going to go back to normal because alcohol was the initiator of all that decrease in free fatty acid oxidation. Now let's talk about alcohol hepatitis. It requires sustained long-term consumption. Swollen and necrotic hepatocytes with neutrophilic infiltration, Mallory bodies, which are intracytoplasmic eosinophilic inclusions of damaged keratin filaments. Intracytoplasmic eosinophil inclusions of damaged keratin filaments. What are the Mallory bodies? Mallory bodies are the keratin filaments that are present within the intracytoplasm, and they are seen as eosinophilic inclusions. Okay, and we see alcoholic hepatitis. Again, this is also reversible. This was also reversible. We can see this after we have seen a sustained long-term consumption of alcohol. Okay, which forms these swollen necrotic hepatocytes, where neutrophils also come, and Mallory bodies. So neutrophilic infiltration and Mallory bodies. Alcoholic cirrhosis. Now this is irreversible because it is cirrhosis now. Final and usually irreversible form, sclerosis around the central vein may be seen in early disease. Regenerative nodules surrounded by fibrous bands. Look at the picture C. You have the regenerative nodules. These are the regenerative nodules surrounded by a fibrous band. This is the fibrous band. In response to chronic liver injury, which leads to portal hypertension and end-stage liver disease. Okay. Now the thing is, again, if you go back to your normal pathology, how, when you give alcohol, how come you had the decrease in free fatty acid oxidation? How? So that has to deal with the metabolism of liver. So remember the ethanol, alcohol, same thing. For the metabolism of that excess alcohol gets converted into acetylaldehyde by the enzyme alcohol dehydrogenase. That acetylaldehyde gets converted to acetic acid by the enzyme acetylaldehyde dehydrogenase. And in all of these cases, you are forming NADH. So you are giving NAD. You're giving NAD and forming the NADH. Again, same thing. NADH. And these NADH, they accumulate so much that you have now increase in NADH to NAD ratio. Now you have NAD, you have used up so much NADs. So you have the ratio of NADH greater than the NAD levels. Now when you have, go back to your biochem, when you have way more NADH levels, it is going to go directly to your bed oxidation, and it's going to inhibit the whole process of free fatty acid bed oxidation. So this is the thing which is causing inhibition of the free fatty acid bed oxidation, which then causes the triglyceride accumulation within the cytoplasm of the hepatocytes, which then causes, let me just write here, which then causes hepatic steatosis. And if you were to do this sustained long-term consumption, this hepatic steatosis, now you will also have neutrophilic infiltration with mammillary bodies formation and necrosis of hepatocytes, swollen and necrosis of hepatocytes. If you have sustained all of this and you keep drinking, finally these necrotic hepatocytes and inflammation because of this neutrophils, they are going to lead to alcoholic cirrhosis, which is now irreversible. Now the whole liver is dead and damaged. Why? Because now you have those E2 cells, they are stimulated, they form, instead of regenerating these necrosed hepatocytes, they release TGF-beta, and they cause fibrosis. And the fibrous band starts forming between the hepatocytes, and now it's called cirrhosis. So that's the whole idea of how alcohol, very important actually, how alcohol does its job on liver. Okay. Now let's talk about non-alcoholic. That was steatosis because of alcohol, right? And the other steatosis we looked at was due to aspirin. But now they're saying non-alcoholic. The patient is not taking any alcohol, and you have fatty liver disease. Okay. Now this is associated with metabolic syndrome, obesity, insulin resistance, hypertension, hypertriglyceridemias, and decrease in HDL levels. Obesity causes fatty infiltration of hepatocytes, fatty infiltration. Look, obesity, lots of fat going to the liver. It causes cellular ballooning. Look at the picture, balloons of being formed, cellular ballooning, and eventually necrosis. Because when you have the cellular ballooning, the normal mechanism of cell cannot work, so they are gonna go into necrosis. And steatosis means present without the evidence of significant inflammation of fibrosis. So steatosis is basically saying fatty liver changes are present in metabolic syndrome people or patients without any significant inflammation or fibrosis, may persist or even regress over time. You have the metabolic syndrome, it may persist, or if you it may regress over time. Now let's talk about non-alcoholic steatohepatosis. This is sort of a lobular inflammation. Now this guy didn't have no inflammation, but here you have inflammation and hepatocyte ballooning, which leads to fibrosis, may progress to cirrhosis and HCC. Okay. So that's called so basically two types, right? Two types. One type this thing and the other type is there. So let me just write here. So 1 and 2. The first one was the NAFL, non-alcoholic fatty liver disease. That is just the fatty liver, nothing else, no inflammation, just fatty liver. And why? Because of all the fat from the body. It's just liver getting fat without any inflammation or fibrosis or any malignancy or anything. But here, the other one is the non-alcoholic steatohepatitis, NASH. NASH is hepatitis. Steato means fatty change. Hepatitis, inflammation of the liver. So here, it is associated with inflammation, lobular inflammation, and fibrosis, plus fibrosis. Because of inflammation caused fibrosis, that fibrosis led to cirrhosis, right? And this cirrhosis, and whenever you have this cirrhosis and anything, it can potentially lead to formation of carcinoma, HCC. Okay. So, yes. That's pretty much for the non-alcoholic fatty liver disease. Now let's talk about autoimmune hepatitis. Autoimmune is the chronic inflammation, liver disease, more common in females, may be asymptomatic or present with fatigue, nausea, pruritus. Often positive for anti-smooth muscle or anti-liver kidney microsomal antibodies. Labs are increase in ALT and AST. Histopath portal, periportal, lymphoplasmacytic infiltration. Then that is just in autoimmune. So autoimmune, you will have some antibodies, And so looking here, we have these. We have the anti-microsomal antibodies causing autoimmune hepatitis, and so you will have increase in AST/ALT. Also, you will have a portal periportal plasmacytic infiltration also. So lymphoplasmacytic infiltration in autoimmune hepatitis. The last one here, we have the hepatic encephalopathy. Cirrhosis causes the portosystemic shunts, which causes a decrease in ammonia metabolism. Okay, and that causes neuropsychiatric dysfunction, which is reversible. Okay, and remember, when you have a decrease in ammonia metabolism, it goes into the blood. From blood, it crosses the blood-brain barrier. From there, it causes the neuropsychiatric dysfunction, ranging from disorientation, asterexis, which is the flapping hand and tremors, to difficult arousal or coma. What are the triggers? Triggers are you have increase in ammonia. Either you have increase in production or decrease in removal. Increase in production and absorption. You have produced more, and you have absorbed more due to GI bleed, constipation, infection. You have decreased removal of that ammonia due to renal failure or diuretic or bypassed hepatic and calf by the tips. Treatment is lactulose. What was lactulose doing? It was increasing the conversion of ammonia into ammonium, NH4. So ammonia to ammonium. That's the mechanism of lactulose. Lactulose. The other thing is rifaximin. Rifaximin decreases the ammonia production by the gut bacteria. Okay. And how is that occurring? So normally, if you let me actually do that here. So normally you have some nitrogen products in the gut, which get converted into excuse me, sorry, nitrogen products, which are going to get converted into ammonia by your gut bacteria. So now you have ammonia in the gut. And normally, that ammonia, that just goes out, or even if it gets reabsorbed, then the liver is functional. It's going to work out and then send it out. But the problem here is we have ammonia, nitrogen products in the gut, and the gut bacteria forms the ammonia. So we give rifaximin. They are going to destroy the gut bacteria. When they destroy the gut bacteria, those nitrogens cannot form into the ammonia. But even though if they do form into ammonia, we give lactulose. That converts ammonia into ammonium, which directly gets out into feces. Okay. And this rifaximin is a non-absorbable antibody. Okay, this doesn't get what stays within the lumen, destroys the gut bacteria, and doesn't let them convert nitrogen into ammonia. Okay. All right, that's pretty much it.